Greetings, everyone, and welcome to Bright Spots in Healthcare, produced by Bright Spots Ventures. I'm Eric Glazer. I'll be your tour guide today. Uh, our mission is quite simple, and it's to spotlight what's working in the industry and to help scale it. Or help show how you could scale it. We bring together leaders from health plans and hospitals and other innovative healthcare organizations around the land to share proven strategies and tactics that drive measurable impact. And through our podcast, our private industry executive councils, and our go-to-market strategy work, Bright Spots Ventures is helping surface innovations that work in real-world healthcare settings. This is all about building relationships. I like to think of podcasting as kind of building relationships at scale. And we've been doing this show for a long time, and we're trying to foster these trusted relationships that fuel progress because we believe the best way to improve healthcare is to find what works and then actually clone it. So if you haven't yet subscribed to the podcast and you want to hear health plan and health system leaders and innovators talking about things that are working and give you ideas on how to scale it at your organization, you should subscribe to Bright Spots in Healthcare. Not to hear me ramble, but to hear all the great guests like the ones you see in front of you today share their incredible insights. Today's episode, we're going to focus on challenges tied to Medicare Advantage and how Medicare Advantage plans can unlock better outcomes and improve star ratings all at the same time. And we're going to call it stars, savings, and satisfaction. We have an incredible panel today. We're going to post their bios in the chat and in the podcast description, depending on how you're consuming today's content today. But I will introduce them right now. And first, we'll start with our physicians. We've got Dr. Mary O'Connor. She's the Chief Medical Officer and co-founder at Vori. We have Dr. Jason Marola. He's the Chief Medical Officer at MVP Healthcare. We also have Vanita Pindolia. She is the Vice President of Medicare Star Ratings at Emergent Holdings, part of Blue Cross Blue Shield of Michigan. And we have Charlotta Erickson, the Lead Director of National Value-Based Care Partnerships at a little company called Aetna. So thank you all for being here, and thank you to Vori Health for supporting today's episode. You could check Vori Health out at vorihealth.com. Their work is a great example of how rethinking specialty care, MSK specifically, delivers great outcomes and higher satisfaction for your members while keeping the costs under control. And that's the idea. The real progress often comes from reframing the challenge. That's the idea for today. And it is going to allow me to set the stage very nicely. So I was thinking about how I wanted to start off today's episode. And I thought about Apple and when they relaunched the iPod. And they weren't the first, or when they launched their iPod. They were late to the market in the MP3 space. Most of their competitors were focusing on technical specs and megabytes, right? Battery life, file formats. And Apple, while everyone zigged that way, they zagged. They simply talked about how 1,000 songs could fit in your pocket. Very simple. And that one shift in how they framed things, changed consumer behavior, reset everyone's expectations, and ultimately not only changed how we consume music, but it changed basically how we consume information. So when I think about healthcare and Medicare Advantage, I don't know if it's the opportunity there is no different, right? Progress doesn't always come from those massive overhauls or new legislation. Sometimes it's coming from looking at a familiar challenge through a new lens, reframing incentives, contracts, care models, so members experience something different, something simpler, more effective, and more human. So, for example, today you're going to hear about how MSK-focused partnerships are helping plans cut unnecessary surgeries while also improving stars. You're also going to hear how one health plan has rethought and simplified specialist incentives with their cardiologists, creating alignment that drives better outcomes without more cost, and a lot more. And so these examples you're going to hear today, these small shifts can outsize, they can create outsized impact. And so that's the spirit of this episode today, star savings and satisfaction. And we're going to talk about when plans, how you could zig when everyone else is zagging, and unpack all of that. So with all of that in mind, Vanita, I'm going to start with you, and let's talk about how Blue Cross Blue Shield of Michigan is incorporating star performance and care gap closure directly into your provider contracting strategies, because that's a little bit where this all starts, and what impact you're seeing on provider behavior and your overall plan performance.
Yeah, thanks for that question, Eric. I think many plans have, for years, we've provided incentives to providers. If you achieve this on this measure, you can get this payment. If you achieve this, then I think we've all moved on to some upside, some downside. And what we've launched a few years ago is, and we have close to 30% of our membership now, and understand we're the seventh largest MA plan in the nation, even though we are just Blue Cross Blue Shield of Michigan, but we just have so much of that, right? And so, with that being said, that is where it's just a full risk contract. And we've embedded in there STARS measures, not just looking at HEDIS, which I think is what typically people think of with providers, but we're able to do even caps by looking at the CG cap scores and having it equated to what a CG cap scores could equate to a caps because the CG cap scores are always higher than the actual cap. So having that, but so being able to embed that into the contract, embedding some drug adherence measures, so some of the clinical stars measures in there as well, knowing that the provider might not be the one who chases members down for drug adherence. But honestly, if they have a prescription that needs a renewal, no matter if a pharmacy talks to them, a anyone talks to that patient, we're not going to be able to do anything until we get a prescription renewal. So we definitely need our providers engaged with that too. And we saw that the plans that, the providers that went and jumped in, like, oh, yeah, I want in, as expected, were some of our higher performing groups, right? So that those physician groups were, but what we are seeing year over year, they're continuously improving. So it isn't like they came in high, easy money, and then they're going to just stay there. They're continuously improving. And so that's really been helping to shape this when they're such a large number of our membership.
Is there anything specifically you find that has specifically improved with like this new approach to partnering with your providers? Is there anything that when you think back, I don't know, before you were doing this 5, 6 years ago versus today, that like, okay, this has immediately changed? Is it exactly where you were going with the incentive or something other
No, I
than?
think it is. Like we've looked across all of our measures. They're all improving. So it's not just one. I think the big difference there is also being able to make sure we're giving timely reports and they're being consumed timely, which isn't always true when you kind of just give reports to all providers because they're now at risk. They're consuming it timely. They're asking questions, which means that they're really trying to understand and allowing us to make sure the messaging is appropriate. So I think that's a key part of this relationship too.
Great. Charlotte, why don't we talk also about how Aetna's doing it? How are you approaching specialty care within MA?
Yeah, absolutely. And of course, I'm speaking from very much that value-based lens. And as you mentioned, Medicare Advantage, I always caveat that. We, of course, I think like most payers really started in the primary care space with, value-based care, recognizing then that there is a limit to the penetration that we can have and the impact we can have just with primary care. And so that's the evolution over the last several years, where first delving into polychronic, then a couple of years ago started standing up our chronic kidney disease partnerships, and then have also moved into the oncology space. And as you mentioned at the top, that we are now exploring musculoskeletal and also cardiology. So, really, our strategy here is that we're all in on specialty. It's the timing of this is really great. We have there was a study in JAMA that was released last week, really focused on how fee for service quality compared to our value based our members who are in value-based payment models perform, and the results are exactly what everyone would expect, right? So we see better performance in our value-based payment models, and that's amplified when we look at two-sided risk, right? So That really is our thesis, I think, as most are. And so really working off of that. So we see particularly polychronic and kidney, we can borrow a lot from the primary care space in terms of where we focus our quality. So, some of those HEDIS measures that Vanita mentioned, but then also as we're moving into new specialty areas, also thinking about, how we move beyond HEDIS and how we're measuring that quality.
What would be, when you're thinking about polychronic or just any of the different, maybe if you have impact results, whether it be around kidney, oncology, but specifically, is there one or two levers that you've pulled that you think have had the most impact to allowing both plan and specialists to be rowing in the same direction?
Yeah, so I think it's identify. I mean, this is where again the two-sided risk. And we are, of course, we're not necessarily partnering at the specialist level. This is where we're looking at these larger specialty value-based care partners, similar to Vori's model. But where we can figure out those synergies. So, I mean, I think about like the kidney space where, it really isn't about the kidney disease so much as the comorbidities. And, if we look at then how those partners can engage with primary care and really amplify primary care, I think that's where we see a lot of the success in, for example, we can control blood glucose or, controlling high blood pressure, and that leads to then the curbing of progression of kidney disease.
So something you said, I kind of want to make sure I understood correctly, because it's an interesting one. And those who know me know I spent almost 13 years working for a large digital telehealth provider, Teladoc Health, it's no secret. And what you're saying is, okay, well, we're not necessarily going out and trying to turn specialists into value-based care providers. We're going to organizations like a Vori, not to be too commercial here, but like a Vori or others who already have the specialists and the value-based care model built, and we're just going to work with them directly. And all of a sudden, we're taking this specialty value-based care, fully cooked, vetted model and contracting versus doing all the work and trying to get providers to change behavior, et cetera, et cetera.
Yes, that would be our primary strategy right now. Absolutely.
Okay, I love that. And that's a little bit of an interesting menu item that we're going to put next to MVP Healthcare here. I'm going to bring in Dr. Jason Marola. So Jason, you're doing things specifically with cardiology that I thought was really interesting and a little bit different. So how are you combining sort of the fee-for-service specialty model with value-based care principles to enable specialists both to do well, right? Not to take necessarily haircuts or downside risk per se, but also support your business and what you're trying to accomplish.
Yeah, so I wish that we could be as successful as Charlotta has been in pushing the envelope on value-based care with specialists. We got some traction with CKD and end-stage renal disease and nephrologists and with oncologists, but it really stopped there, Eric. And it was frustrating. Whether it be attribution or our accumulators or coming to agreements about what the acceptable outcomes to measure would be, we really lost traction. And in 2023, we had a new president join our organization. He's a cardiothoracic surgeon who's also boarded in preventative and lifestyle medicine, interestingly enough. And, he pointed us in a different direction and said, why don't we think differently about value and what kinds of services that the specialists are providing? And so we went ahead and looked at our network, and sure enough, there were a lot of specialists providing primary care-like services and preventive care-like services. We had endocrinologists who had prediabetes clinics, and we had a number of cardiologists that had metabolic clinics, and we had bariatric surgeons that had multidisciplinary weight loss clinics. And so we went ahead and really tried to partner with these providers to deliver valuable services to a patient population that was significantly broader than they would otherwise have exposure to. So from their perspective, we were able to, broaden their referral pattern and their downstream referral pattern for their specialty services, as well as diversify their income streams and allow them to provide better care for our patients. From the patient's perspective, it's very satisfying. They feel like it's a concierge experience for us to onboard them and then direct them to these types of programs. And we're able to then weave in on the backside of it reimbursement for gap closures, such as medication adherence or blood pressure, cholesterol control, diabetes control. And so the model is a fee-for-service model on the visit side, but then upside only for the providers in terms of incentives for the quality gaps. So, we'd love to get to a full-on risk model. We haven't been overwhelmingly successful. This is sort of a step that we've taken in that direction that allows us to engage with our providers and our members to provide what we think is valuable care.
Perfect. So I like this because we've got sort of different and yet similar different models on how to just do a better job controlling specialty gaps in care. And I think so. We're going to put those. It's a really good sort of foundation for the rest of the conversation. So I'm going to bring in Dr. Mary O'Connor, and Mary, as everyone is sort of navigating now the changes we're seeing both in the STARS programs coming up and the cut point tables and the importance of improving, and maintaining sort of health, and we got the 3 times kind of coming up in 2027. What do you see as low-lying fruit for health plans to tackle and ensure they're making the best possible impact? Because there's going to be all things that are going to get really complex and comprehensive, and people are going to get distracted. Where can we make maybe a big 80% impact with sort of 20% of the effort?
Eric, that is the great question. And I think it basically comes down to focusing on improving the health of individuals in terms of their level of physical activity, right? And that STAR measure on improving and maintaining physical health will be triple weighted in 27, as well as the STAR measure of improving and maintaining mental health. So why is MSK so critical? Because we know if individuals are more physically active, they have a lower risk of obesity, hypertension, heart disease, diabetes, and depression. And we oftentimes don't appreciate how closely depression is linked to patients with chronic MSK conditions. So in the Medicare Advantage population, obviously older individuals, there is such a high prevalence of MSK conditions. So getting those individuals the support to address their MSK issues so that they can increase their level of physical activity, improve and maintain their physical health. Also, it will improve and maintain their mental health is key. And we know that, and there are studies that will show that when you compare physically active to inactive groups, there's lower healthcare costs for the active groups ranging from 9 to almost 27%. So it is the unifying theme that impacts all other, I'll call them service lines, heart disease, lung disease, even kidney disease, everything. So, like if I was queen of the universe, we would have everybody being more physically active in this country, because that would automatically improve the health of our communities, our country, lower our healthcare costs. That's really where it's at.
Perfect. As far as, can you talk specifically about maybe a health plan that you're working with and how that digital experience is helping promote all of what you just said in a way that, gets us in a better position for that 3 times impact in 27?
Absolutely. So, when we're working with a partner, and a health plan, we are very focused on supporting many STAR measures that are directly relevant to MSK. So it's not just improving and maintaining physical health and improving and maintaining mental health. There's, monitoring physical activity, pain assessment in the older adult, osteoporosis management for women that have had a fracture. I'll come back to that in a minute. Fall risk reduction, improving bladder control, right? Your MSK partner should also have a pelvic floor program that members can access to help with bladder control, which is a big issue in the older population, whether that's a female with stress urinary incontinence or the male who's had prostate surgery or some kind of prostate treatment, right? And then access to care, so getting needed care and getting appointments and care quickly. It's not necessarily so easy for a Medicare Advantage patient to go get an appointment with an orthopedic surgeon. Now, if they had commercial insurance, it would probably be easier for them to get a timely appointment. But that's not necessarily the case with Medicare Advantage programs. And we're also seeing more healthcare systems and hospitals saying, we're dropping Medicare Advantage contracts. So we bring a lot of value to our partners because we impact all of those STAR measures that I just mentioned. And one that is particularly, near and dear to my heart is osteoporosis management for women that have had a fracture. Because it is, I'm trying to find the right politically okay word I can use for you, Eric. It is abhorrent that we don't do a better job with these patients, okay? And I'm an orthopedic surgeon, but I can tell you the orthopods are never going to do this. And the PCPs don't necessarily get the patient back. There's like this, why is this so difficult for us to get better care for this extremely high risk group of patients? So we do a lot to help address that gap for our partners.
Yeah, I love that. For my late grandmother, osteoporosis was the bane of our existence and her existence. And we were all over it too. So great stuff. I want to, I forgot to let everyone know who's listening, if you want to help me co-moderate, there's a Q&A, as you should all know, there's a Q&A module at the bottom of the screen, talking to you like pre-COVID days, but you could post questions in there and then keep the questions off of chat. You could use chat, but don't post questions there because it's harder for my team to manage and us to kind of integrate them into the flow of the conversation. With that said, I'd like to ask everyone else who's listening a question. We have 2 exciting episodes or programs coming up that we want to know if you want us to send you more information or pre-register for you. We have another show coming up on October 9th around the GLP integration playbook, and we're going to talk about plan design and member engagement and some of the new things coming around as everyone's sort of getting their hands around the weight loss management GLP-1 stuff. So if you want to join us for that episode, we have an incredible group, and I think we're going to be adding a 4th guest too. So that's a great show, and I've been just going through prep meetings with those guests today. So I can assure you it's going to be a super conversation like this one. And also, if you're at a health plan, next week, we do these private events now. It's something we new in 2025, where it's like a 4 to 8 person private event. So if you're with a health plan and you want to talk about risk adjustment and AI and Medicare Advantage, we'd love for you to join us on Wednesday, October 8th. We're going to have a private event around that topic, and that should be really interesting. All right, Vinita, I'm going to come back to you because there's this tug of war, right, that doesn't get at least talked about during a lot of episodes between utilization management and how that can conflict with folks who get compensated and come to work every day around stars and caps and member satisfaction. So how are you dealing with this sort of, competing interest in using analytics and collaboration to balance those 2 parties so that you could better manage costs, right? Which is important, but also you don't want to jeopardize caps or readmissions for that matter.
Yeah, I mean, I think that's a really good area that the intersection doesn't always happen in the collaboration within the health plan. is in a separate wing, so to speak, right? And then you got quality in another wing. I'm very fortunate, I think, and partially it's maybe because of my background, and I did do a lot of work in the clinics and the provider space as well, and doing but that is a key part of what we do here at Blue Cross Blue Shield of Michigan is as there are new activities being considered for MA, I look at it from the lens of stars, and it's not even caps. It's looking at, okay, what's going to happen to the appeal volume? What could be happening to complaints to CMS? So there's operation metrics that can get hit too. What is the actual cost benefit? Is that going to be realized immediate? Is that going to be later? If it is later and cap season is around the corner, is there anything that we can maybe delay this by 3 months or 6 months, right? So even the timing of when to launch. And then once we're landed, like, no, this is critical. We need this because our cost of care is really not in line and national trends in this area. Then it's looking at the analytics of, okay, how many members with that particular disease state or that particular area fall into currently having the number of volume of denials as with other processes in place, how many of those result in appeals, to then understand if with this gets ramped up, what could that escalate to? Is our appeal team ready to handle that? That's the other part. Like, are they manned up to make sure they're going to be able to do this because of the timeliness that we need? Um, do we understand that if we're going to deny this, do we have really clear language that could align where CMS is going to say, this does not put the patient in the middle, right? That we are looking out for the patient's interest, not just cost interest. So putting all those components and lining that up too before all this launches versus reacting after the launch and then hearing like, oh my God, our call center is being swamped and we didn't expect this. So having our CSRs, having the appeals, having all that lined up, I think is critical as we go through that launch process. So it's not to prohibit it, but it's to make it so that it's planned across multiple departments that can get impacted, that eventually could impact stars.
So if I could summarize that, and if I'm starting a brand new health plan on just MA, and I'm thinking, all right, I need real good tech so I can look at the analytics, and then I got to have a culture of collaboration. So that's what I'm hearing. Or am I missing? Is there another lever that maybe I'm missing in your answer that we should make sure we bubble up?
No, I think the culture of collaboration is missing in many areas in these two when you think of it. So I think that's such a critical. I think stars, everyone knows as numbers, right? It's analytics, but maybe run the analytics in a different lens, not just purely from the stars, but then you combine what does that mean for What's our current volume? What would that increase? Are they targeting specialists? Are they targeting physicians that are in meaningful risk? Are they not? That could also mean what kind of communications should we want to do beforehand. How do we want to help our members understand beforehand instead of them hearing it as they're wanting a procedure? I mean, that's critical too. So
Right.
there's so much that we got to get lined up.
So you're taking out the folks for drinks a lot. Is that what you're saying?
No, we don't have the money, right? UM's to save the money.
All right. So Charlotte, how at Aetna are you balancing cost and quality goals that also protects, the caps and the member satisfaction and overall engagement?
Yeah, great question. I do have to start with Anita. When I heard you talk about your ability to report at the provider level on caps, I'm very jealous. So in the absence of that, because I'm of the opinion, right? Like, I mean, we know it because of how we're incentivized as a payer, but just from a general perspective, patient satisfaction, member satisfaction is an outcome measure. And so what we've done at Aetna, really focusing in on these large national partnerships, is how do we really protect that member satisfaction? And what that means for us is minimizing member abrasion. So we know specialty value-based care is very different from primary care. So there is not typically an existing patient-provider relationship. So that's where, we're relying on our specialty partners to engage with our members, engage them in their care models, because again, we've bought into this. And so this is where, our specialty partners are outreaching our members, right? They're calling, they're sending mail. And so, in all lines of business, but especially Medicare Advantage, there is a lot of skepticism to engage. So if we inadvertently are abrasive in any of these methodologies, right, then we're not going to actually get the engagement that we want, get the outcomes that we want from a cost and quality perspective. So this has meant, spending a lot of time training different teams internally, right? So that point about collaboration. So we train our member services reps, right? We make sure that if a member calls in and they're asking about a specialty partner, that the member services rep knows this is legitimate. It's not a quote unquote scam, right? And they can say confidently, they have the information, they have a flag in their system to say, yes, this is legitimate. We want you to engage. Similarly with care management, right? While we use an attribution model, that we do our best then to encourage engagement through our care managers. Our care managers are trusted by our membership. So if they can say, oh, by the way, I see that, you are in active chemotherapy treatment. Did you know that you can get extra support from our oncology partner?
That's great. What would you say, how are you able to get, if there was an ingredient that you put in place here that is allowing all this to work? Like, could we like open up the black box for a moment? Is it through small pilots, testing it, expanding it? Is there something around the processes you have in place? Is it something around the work you're doing with the specialists that are driving better relationships? Like what's a little bit behind the scenes of what's making this really work as well as it is?
Yeah, a couple of things. I mean, everyone always speaks to data, but the more that we can integrate data into these processes, so, right, a care manager can say, this member is eligible for X partner without, 10,000 clicks. But one thing that I think we've learned along the way, we're still relatively new in our journey into specialty and polychronic care, but just how much implementation pre-work is required. I mean, some of it's just project management 101. But it's really evaluating, what are going to be all the downstream impacts, and then how can we get ahead of that? And it goes way beyond contracting, which is, of course, what I thought my job probably was when I started here, but then, really touches so many more areas of the organization. So that's where I would say, this idea that, we've got robust implementation planning processes in place and the data to enable all these various teams to understand what we're doing.
Okay. So I'm going to shift gears a little bit, but not entirely, because we're talking some of the pressures that CMS is putting on all of the health plans listening today and on the panel. So Mary, there's also the spotlight on ghost networks, and health plans are sort of figuring out, they need to prove that the directories are translated into actual access. So this is a compliance headache, and there's stars penalties waiting to happen. So how do you think plans could flip the narrative and treat the network adequacy as an opportunity to differentiate themselves in the market versus just deal with it as a check the box compliance?
Right.
Sure.
Eric, that's a great question. And I think expanding the definition of network to basically include digital first specialty care is really important. So that digital front door is going to improve access and convenience for members. And of course, not all MSK care can be delivered digitally, but a huge amount can. And so the further kind of upstream we get, the greater the impact we're able to have on appropriate care for that patient and appropriate utilization of services. And I'll give you an example. So we just submitted a clinical research paper looking at about 1,100 patients from some of our partners. And I wanted to know how my physicians were doing ordering MRIs of the lumbar spine in patients with low back pain, because that is a huge population that we see, because we know a lot of Medicare Advantage patients, right? Older population, back pain is a very frequent concern. our rate of ordering MRIs in that population, that 1,150 some patients, was just under 3%. Now, if you compare that to what's out there in the published literature, you're going to see results that would be 12 to 18.5% of studies being ordered. So we are, and my second question was, okay, I need reassurance that we're actually ordering the studies appropriately, like we're meeting quality criteria for appropriateness for ordering the MRIs. We use the American College of Radiology criteria, and we met those criteria in basically 91% of our patients. So there was about 9% of patients where our physician ordered the MRI and it didn't actually meet the criteria. I'm okay with that. You know, the physicians need a little bit of wiggle room from my perspective to navigate these gray areas and utilize some clinical discretion. But should the vast majority of our scans that we're ordering meet the criteria? Absolutely. So I was really excited about those results. And when you look in the literature at the rate of inappropriate scans being ordered, so we're at 9%, that ranges from 26 to 44% of inappropriate imaging for low back pain patients. And this, of course, starts the patient on this journey of potentially inappropriate care, which also tends to be costly care. So I think that looking at how plans can expand their network to not essentially have ghost networks, one opportunity is for them to partner with digital first companies. Because from an access standpoint, right, we're nationwide. We can see patients anywhere. So I think that that's a strategy for them to consider.
Yeah, I mean, obviously, in some ways, CVS is validating that today, right? I mean, excuse me, Aetna, sorry, shall I? So something, if those of you are looking to think about digital first, and if you want to leverage some of what Vori has done to do that, and you don't necessarily have to consider Vori as a partner per se, you should, but you don't have to. But they have a report out that can help you with your business case, and you can grab some data and some language from it. It's called Maximizing the 2026 MA Performance with Physician-Led MSK Care. And of course, it was produced by Vori, so there's going to be some branding there and certainly maybe a little bit of bias, but it really talks about how physician-led virtual first MSK solutions could not only improve capacity, improve quality, reduce all that ghost network stuff, and it could allow you to think through sort of your digital strategy for all their specialties too, right? Not just MSK. And so if you want to get a copy of that report and the data behind it, right, and how what in the field Vori is seeing as far as success, there's that poll, it's already out there right now. We could send you a PDF of that right away after the show and get you some of that information. I think is a really good way of building a business case internally or expanding what you're already doing. I also think they're just terrific, and you could probably get that drift just from hearing Dr. O'Connor Mary speak, but they're awesome. So they have good content and they're good sounding boards for all of this. And again, check them out at vorihealth.com. But if you really want to understand how to better improve outcomes, reduce costs, strengthen your whole MA star ratings positioning, you should definitely talk to these guys and think about that overall strategy.
Eric, can I just add one other comment?
Yeah.
I think, and this is not to speak in any negative way regarding other companies that are in the digital MSK space, but we are the only company in the digital MSK space where we have physician-led care teams. So some people will talk about, yeah, we have doctor-led care teams, and they're referring to doctors of physical therapy. And that is not to denigrate in any way physical therapists. They're core to our model. We love our PTs. But you cannot provide care to a population of patients unless you have specialty MSK physicians involved. And you will not get a reduction in just the data that I shared on reducing inappropriate MRI imaging of the lumbar spine, for example, unless this model is one where it's truly integrated between the physician, the physical therapy team, health coaching, registered dietitian for nutrition. So that's just my plug for why having a physician as part of this care team is so essential.
Good stuff.
Yeah.
Good stuff. Sorry, and I should have mentioned that physician line. I think I have, but I liked how you emphasized it there. So I want to switch now. Let's talk a bit about innovation. I'm going to come back to you in a second, Mary. I'm going to bring in our resident primary care doctor, Dr. Jason Marola, CMO of MVP Healthcare. So, Jason, how is MVP innovating and thinking about the future as it relates to just network capacity and member experience?
Yeah, so I couldn't agree more with many of the things that Mary just mentioned. A digital approach to network management is critical. We spend a lot of time here at MVP, Eric, journey mapping patients' healthcare journey from wellness to chronic illness to sick care and end of life care, and we overlay on that what our network looks like, that be providers or community-based organizations, to be able to fulfill all of the jobs to be done. And there are major gaps in the brick and mortar networks, and we have decided to take a service line approach. And I heard Mary use that term before. In our world, it really means building out a journey for patients for particular conditions, whether that be kidney disease or heart disease, or maybe it's pregnancy. And then providing them not only with information, but also access to care that they might otherwise find challenging to receive, a digital first approach to accessing that care. And as an example, for our pregnancy service line, we have a lot of information, but then digital access to doula services, and we also have lactation support, and we might have post-delivery behavioral health support, all digitally. We have a vendor that we use in our women's service line to provide support for perimenopausal changes. We have a virtual PT program in these various service lines. And so we think it's very important to understand what your network gaps are. And it's also very important to utilize digital resources for all the reasons that Mary outlined.
Stop. I'm gonna bring in Charlotta now, and I kind of want to stay with this line of questioning, and based upon what we just heard from Jason, what we heard earlier from Mary, as you're thinking about your specialty value-based care principles and partnerships, and I alluded to this the last time I asked you the question, but I want to get now into like blueprinting, right? So what do you see, Charlotta, as the key components for like these types of specialty value-based care programs to succeed? And also specifically for CVS, but in general, if you're providing sort of a professional-like course right now for everyone watching and listening.
Yeah, there's really two prongs here. There's member engagement, which I touched on some of the things that Aetna is doing to enable engagement of our specialty partners with our members. I think the other piece that is maybe sometimes forgotten is provider engagement. So how are our specialty partners engaging with those community providers? And a critical one really for all specialties is PCPs. And so this is, we as a best practice, doesn't matter the specialty, but we do warm introductions between our specialty partners and our high volume PCP groups. So we want to make sure that they're communicating with each other, they're establishing their communication channels, communicating about their shared members. And so we don't see our specialty partners as in any way, shape, or form replacing our primary care docs, but really this is where they're supplementing and really providing added support. So that's where I think, there is, of course, a role for us as the payer, again, to broker those introductions. But then on the other side, I think, for, these specialty partners, so, Marriott, Vori, I think y'all have this in your strategy, but what are you doing kind of boots on the ground to engage with those community PCPs? Of course, for the various specialty areas, there is a need to engage with a specialist as well. But I do think that real focus on, collaboration between PCP groups and these specialty partners is really critical to success.
Okay, so partnerships between primary care and specialty care, and you guys serving almost as the matchmaker, the broker between the two of them. Kind of like me with Mary, right? And Jason, right?
Exactly.
Which is-
No, exactly.
Yeah. Eric, I'd just like to comment because I think Charlotta's comment is so very important, right? PCPs need to absolutely be kept in the loop. So we, of course, as standard practice, are sending our clinical notes to the PCP. Our docs will pick up the phone and text them or call them, hey, do you have a couple minutes to speak about if the patient's particularly complex, right? That goes a long way in making sure care is coordinated. And if you think about it, like back a few decades ago, like this was much more common in the practice of at least orthopedic surgery and specialty care, where we would actually like call the PCP. And now like nobody does it because nobody wants to take the time to do it. So it's really, I can't emphasize how important that is. And we work very hard to keep the PCP in the loop. It is their patient. And we have the, privilege of supporting them and supporting their patient with specialty MSK care.
So I was going to actually ask you, like, if we were building this digital first specialty care strategy to support STARS next year, 26, what would it look like? It sounds like that's obviously that's a massive part of it. Is there anything else you want to add on top of that?
I think that the question of, encouraging and supporting patient engagement to get them to do their home exercise program is a very important one, because we know that a lot of patients don't complete a prescribed physical therapy program, even in the in-person PT setting. And part of those reasons are out-of-pocket costs. So one of the things that we really try to focus on when we are working with partners is to say, when your members come to us for MSK care and we're supporting them with virtual PT, there's no out-of-pocket cost for that member. So that is like to be patient-centered. We want them to be doing their exercises and seeing our PT, etc. So let's remove a barrier for the patient to do that by saying there's no copay if you're getting your PT with Vori.
Got it. Perfect. So we're looking at, we want to reduce barriers to entry, the headwinds, the frictions. We want to create a simpler overall experience for the members when it comes to like, what am I paying? What am I not? I'm paying nothing. It's part of my benefit. And we want to make sure that specialists in primary care doctor are sort of synced at, locked at the hip.
And Eric, there's one other thing. It's important, and we work very hard at this. So some of our partners will have, for example, a behavioral health program. And we will screen every patient with a PHQ-9. And if there's a flag score, we are referring that patient back to the payer's behavioral health program. Okay, so like we want to work in conjunction with our partners. We're not trying to duplicate any services that they're providing. We want to support, it's a strategy for mutual success.
Right. I love that. I love that. A couple of quick things. We have 10 minutes to go and a couple of really important points I want to cover and get to the audience by way of our guests. First, before we do that, at this point, folks, you have received another email from me. I know it's painful, with a request to you to provide us some feedback, which we do each and every episode, and we have for the last 10 years, 11 years now. And it's paramount. It's one of the reasons we have continued to get better and better at providing you the right information. So it takes 2-3 minutes to complete. We'd love if you could take the time to complete that survey. We'll put the link right in the chat too. So if you're watching live right now, maybe you could complete it while you're listening to the last 8 or 9 minutes here. The second thing is we really have been trying to increase, based upon your feedback, by the way, your entire experience with us. And so we will be sending out afterwards. Give us like a day or two. I don't, maybe Monday. I don't want to put too much pressure on Nicole, our producer, but we're going to provide you a key insight summary of everything that was covered today. We're going to take the transcript, we're going to put it through AI, then Nicole and I are going to edit it, and we're going to make sure you get all like the cheat sheet of everything that was covered today, so that not only do you have the recording that will drop on the podcast feed on Tuesday, you're going to have all the key insights that was both not just AI generated, but edited by yours truly and my production team. So you'll have that all coming out of today's show. But please do give us that feedback. Would really appreciate it. I'm not holding the key insights over your head. We're going to provide that to you anyway, but we're hoping you'll do that as a favor to us. Jason, I want to allow you to get a word in here as far as we're talking about engagement and partnerships. And what's MVP found to be most effective for both engaging doctors and then building that strong data-driven relationship with the practices, and how is that all working as you're thinking about HEDIS, gaps in care, and everything stars?
Thanks, Eric. Yeah, so we've had a number of approaches over the years, ranging from sending out reports in the mail or in fax to our current model. And at the end of the day, it all comes down to building trust and collaborating with the practices to help them take better care of their patients and our members. What we've found most effective is and it's not an easy thing to do. It's very intensive, in fact, but a team of clinicians, both nurses and physicians that are from the health plan, that are going out and meeting in person with practices, delivering to them actionable, timely data, and reviewing in a sort of grand round style, or round style, if you will, patients that potentially either have gaps in care or utilization issues or gaps in risk, et cetera. And we have found this particularly effective. They like the clinician to clinician interaction. And when we focus on those medium-sized practices with reasonable attribution, but those that lack the analytical infrastructure or the care management infrastructure to then exercise some action, we can fill that void for them. So there's a lot more collaboration. That has been the model that has been most effective for MVP.
Good stuff. I want to put everything, kind of wrap it into a bow here. So we're going to bring in Vanita Pindolia. So Vanita, you got stars in your title. So why don't we talk about, we're going to temporarily take you out of Michigan. We'll get you into some warmer weather. All right. And we're going to design a brand new Medicare Advantage organization that is fully reliant on stars bonuses. What's sort of the structural or accountability practice you'd put in place from day one? Let's go through that.
Yeah, I think the first thing is making sure the senior executives are aligned on what value does stars bring into the organization, because we need them to understand, as they're having all the other pressures and levers to consider, Stars is just at the top as all the others, such as cost of care, et cetera, right? And claim trend, et cetera. So that's got to be the first thing, that there's the education, the understanding, and what does that do? How does that allow you to stay competitive? Why is that so critical, right? Then the second part is, once that's done, to make sure as you look at every star measure, there's an accountable owner as just a single owner, not a team, not a department, but a single person that you can go to. And then you can have a bunch of executors to help support, of course, right? And this really makes the individual, I think, come up to the table of like, oh wow, this is looking red. I, the one who owned this, I don't really like it looking red. So to have that, make sure that every week executive leaders can see that report card. So it's not just a small team so, because nobody wants their executives to see that you are in red, right, too? And then you want to come bring ideas. This is what I need, because it is a cross enterprise function for stars to succeed. It is not one HEDIS team. It is not one customer service. You need a provider contracting team. You need CSRs. You need so much. You need right? We discussed. So that part. And then the last part would be to make sure there's a strong analytics arm that you have, and that you are able to do your star projections with reliability, and you're able to pivot quickly as you see new data comes out, like we do in September, October, right? And understand if your new cut point projections need to be modified, etc. So I think those would be the three critical things I'd want to stand up right away.
Great stuff. Anyone want to add anything on the No, we're good. Good.
I'll add, Eric, that I think that looking in terms of the network for broad access for digital first can be, I would include that for
Right.
different service lines.
Great. And digital first isn't digital only, right?
Correct. No, absolutely not.
Yeah, exactly. I've seen just a lot of models. I was actually hosting a dinner 2 nights ago in Chicago with a bunch of provider organizations, and a lot of them are creating digital first primary care practices, not digital only, as a mechanism to provide access. It's just a better experience too. So yeah, great stuff. I agree with that. This was great. I really appreciate everyone for taking the time, all of you. For all of you listening, and by the way, we got Detroit, New York, and Boston, go Red Sox, all represented in today's call. It's baseball playoff season, and it strikes me like a lot of these playoff games are not won by grand slams, but they're won by a string of singles. That small, consistent play. So it just ties to what we talked about today in Medicare Advantage, right? I think the progress comes from taking bright spots, small ones, scaling them, aligning these incentives, making the small shifts that together will deliver better outcomes, stronger star ratings, and bring all of you listening who are at health plans to success next year and beyond, with all the noise that we're seeing in the changes with CMS and HHS. So thank you to everyone who's listening and watching for spending the time with us. We do not take that hour you spend with us for granted. A special shout out to our producer, Nicole Roberts, for bringing all these leaders together. Great. And we hope that the bright spots shared during today's conversation inspire your thinking and enhance your company's overall approach to improving healthcare for all of us. We produce this show for you. This is your Bright Spots in Healthcare podcast. Take care, everyone.
Thanks, Eric. Thank you, everyone.